One person.
Are we on?
Yep. Starting.
I'm pleased today to introduce Dr. Sarah Hales. Dr. Hales is a psychiatrist at Princess Margaret Hospital. She's also a researcher who's been conducting research into the quality of death and dying in patients with metastatic cancer. This has been part of her doctoral studies. And Dr. Hales is a clinician and teacher in the area of the psychosocial problems of patients and families with advanced disease. She's going to present her work to us today on the quality of death and dying in metastatic cancer. So,
thank you, Gary. So, what a turnout. I feel like it should be fairly informal. I don't know. Do we know how many people are online? Do we know? Anyway, I'm Sarah. Anyway,
I'm Gail.
Gail. And Gail, are you a student with the institute?
No, I'm a nurse. I'm retired.
Oh, okay.
But interested in this.
Okay, so someone with clinical experience.
Yes.
Excellent. And we haven't met Mandy.
Sorry.
And Gary, I know very well, and he knows all about this. Maybe we can have a discussion and make it sort of informal, given the size, or not, or I can speak about lots of slides. I wanted to talk to you a bit about this concept that I'm interested in, which is quality of death. Sort of the concept, some of its clinical relevance, but also about some of the research challenges in looking at a concept that's as complicated as this. So hopefully there'll be something for people who have a clinical background and people who may be interested in research as well. I'm going to talk a bit about, I'm going to give two examples of two metastatic cancer deaths. And these are actual stories that were part of the research. And that's going to sort of frame the presentation. I'll begin with that and come back to that in a minute. And then I'm going to talk a bit about this quality of dying and death construct and what influences its perception, measurement. Talk a bit about my research and some preliminary findings, and then sort of my plans for the future and where I'm pushing. The idea of the good death, really not a new idea at all. And I think it's something that, if you look at the history around this, cultures have always had ideas about what is considered a good way to die. But in healthcare, in modern healthcare, the interest in this has really developed over the last 10 to 15 years with the growth in the hospice and palliative care field itself. And as the length of the disease trajectory has broadened, there's more time now for end-of-life planning and decision-making. And the scope, I think, is broadening therefore too, from the focus on survival alone to quality of life while living with advanced disease. And I think also influencing this has been the patient's rights and the right to die movements, which have forced healthcare to consider the actual nature of death and dying and ensure that patients and families are getting what they need. I don't know whether people have thought about what they would consider to be a good death. I certainly think about it a lot now that I'm involved in my research. I want to give you sort of two cases that are involved in my project. One was an example of a poorer death comparatively to the other. And I'm going to give you the information about these two cases and have you think maybe about which you would think would have been a better death, and then we'll come back to these cases at the end after the presentation. So the first is Grace, and she's a 70-year-old woman. She was unmarried and living alone at the time of her death. She was retired. Her income was around $15,000 to $30,000 a year. She had had a diagnosis of gastrointestinal cancer for about 11 years prior to her death, and she had been followed by an outpatient palliative care team for 1 year before dying. And then she was in her own home, and then spent the last 3 weeks of her life in a nursing home, and that's where she died. The other case is Daniel. He was a 56-year-old man, married, living with his wife and 2 children, a son who was 20 and a daughter age 18. He had been working as a manager when he was diagnosed with this disease, and his household income was greater than $60,000 a year. He had GI cancer for 3 years before his death, and he was followed by an inpatient palliative care team for 2 days before his death. And he spent the last 3 days of his life on a medicine at Toronto General Hospital. That was when he died prior to that. So if I had a large crowd here, I might take a vote. But Gary and Gail, I don't. What is your guess? Who do you think would have had the better Grace? And why is it?
I guess it's the idea that she had that support with palliative care team and protected so much positive things about the prior to her death.
So
That was what jumped out at me.
We could think about multiple factors, right? That would be one factor. We could think about the family. Does having a wife and family, children, and financial resources.
So I think those are all good points. These are all factors that I've been wondering about, how they contribute to the dying experience, palliative care specifically, and having that kind of support in terms of not only symptom management, but end of life planning, family support, financial resources, where you are in terms of care at the end of your life, medical unit versus a nursing home, all these things are the things I'm thinking about. So you're not going to save this till the end and give you the answers at the end, but before that, I'll give you some background. All of the ideas that you came up with, I think, those are all factors that we often think about when we're thinking about how to die. There are many aspects of the dying experience that are important to people. If you look at the qualitative literature, interviews with patients who have illness, family members, healthcare providers working in the field, they come up with multiple facets of the dying experience that might be important in terms of identifying a good death. So certainly pain and physical symptoms are pretty universally commented upon, but also psychological symptoms, so level of depression, anxiety, the social aspect. Gary talked about family support, but also comfort with dependency, the idea of dignity, which is a social concept, where loneliness has still having an opportunity to contribute to others. The spiritual and existential aspect of dying, very important to people. So are they still able to find meaning and purpose in life? Is there a sense of peace? If there's a religious involvement, are there kind of rituals they want in their life? The nature of healthcare is very important to people in terms of end-of-life experience. So the kind of care you're getting, whether you can communicate with your healthcare providers, what the decision-making process is about treatment, whether you can trust and rely on your healthcare providers. Life closure and death preparation is another very big domain that makes this a sort of unique area of study. So level of awareness about death and dying, level of death acceptance, whether you have a chance to sort of complete your life activities, say goodbye, and if this is important, establish some continuity with the next generation or legacy to leave behind. And then also people talk about the circumstances of death, where they're going to die, when they're going to die, what state they're going to be in at the end of life. So it's obviously a multidimensional experience. It's also very individual. So while freedom from pain and suffering is really commonly identified in the literature, there's a lot of differences in terms of the relative importance of these different domains, and even within a domain, what people are focusing on. So while pain and symptoms, for instance, is often commented as important, people don't want to suffer physically. For some people, it's so important to be alert at the end of life that they aren't just interested in taking opioid medications as other people. So they may be willing to tolerate some more pain for greater level of alertness. So even that is something that people make trade-offs about the end of life. We know there's likely a lot of influences in terms of culture, type and stage of disease, where you are on the trajectory, what your involvement is in the dying experience. Are you the patient, or are you the family member, or the healthcare provider that's making the judgment? But we don't know a lot about those influences, or researchers are beginning. So that's a bit about what people want, but how do we die? What do we know about what dying experiences actually like? And there's been several large studies in the UK, and this is a support study presented United States, that have looked at sort of the circumstances of the end-of-life experience. In the support study, this was about around 9,000 adults that were admitted to 5 U.S. hospitals. They each had one of 9 life-threatening illnesses, one of which was cancer. And of those enrolled in the study, around 4,000 died within the study time frame. And they looked at, for instance, symptoms at the very end of life, and they found there were severe rates, there was severe pain, breathlessness, confusion, fatigue, and moderate depression and anxiety in patients in the last 3 days of life. On average, 55% of these patients preferred to die at home, but actually died in the hospital, and 79% died with a do not resuscitate order, but 50% of those orders were written in the last 2 days of life. So these results are about 10 years old, but there's a lot of suggestion in the literature that things haven't changed much in terms of rates of hospital death. So this was quite alarming, this research. People were very up in arms about it. Look at the level of symptoms, look at the lack of death preparation that's going on. People are dying at home when that's their preference. And I think that it's definitely sounds concerning, but while this tells us about what happens at the end of life, it doesn't tell us actually how those deaths were experienced. And would the people involved with these deaths rate these as poor deaths? Or would they have been the best possible death? Or even a good death, despite some of these aspects. And that's really what I'm interested in. I'm interested in what happens, but I'm also interested in the subjective experience. So if you're interested in that, how would people actually rate it? How would you measure something as complex and multidimensional and subjective as the quality of death? Well, there are obviously a lot of obstacles, and one of the biggest issues is the availability of patient-reported data on something as complex as this. This is a problem in most palliative care research that as patients get closer to end of life, their involvement in research falls off, and there are a lot of reasons for that. And ultimately, the nature of the end of life, the very moment of death, has to be a retrospective report from someplace. So there are these low patient participation rates. Patients often have progressive physical and cognitive impairment as they get closer to death. There often are ethical concerns about talking to patients who have advanced disease about issues around death and dying. Ethics boards and oncologists in our hospital business aren't necessarily always open to the idea of us talking to patients about this. While it can be, knowing if you have advanced cancer, it's likely that you may die from that disease. For other illnesses, it's often difficult to prospectively identify patients that may be in that dying group. And as I said, ultimately, to a spoken of death must have performance. But there's a lot of criticism then of relying on other informants in research to give us this information. So there has been some research that's been done on looking at proxy reports, so patient reports of, for instance, symptoms, and then the after-death reports of their family members about what the patient experienced. And they see really often poor agreement between the patient report and the after-death family caregiver report. And there are a lot of reasons for that that have been hypothesized. The subjective state of the caregiver may be different, for instance, at the time of death and recall. There's a frame of reference of those two individuals. They may have had different experiences and attitudes and motivations in answering questions. We know that length of time between death and recall probably affects what family caregivers have to say about the experience. And I'd say also this idea about ability to take another's perspective, empathize with the dying patient, that's an ability that varies amongst people. So some caregivers may be quite good at guessing what their loved one experienced in some way. Research generally shows that these proxies are most accurate when they're asked about what were more concrete and observable aspects of the patient experience. So what did the patient actually do? What did they look like? And what's interesting is when you look at these family caregiver proxies, they tend to rate symptoms and quality of life more negatively than the patients do on average. So patients are actually saying they have less symptoms and better quality of life often than the proxy caregivers are. So all of these things then complicate using these other informants, particularly family members, in order to capture this the life experience. But many people are saying even if family members can accurately represent what the patient experienced. Nonetheless, their opinions about what happened are very important. In palliative care, caregivers are very involved. As patients deteriorate chronically, they become more and more a part of the end of care at the end of life. They're often making decisions about end of life care and are receiving care from palliative care providers. And there's this idea also that the family perspectives about the end of life may then impact on their own bereavement and distress levels of bereavement. So it's important to understand what their experience was, even if it's not necessarily a valid representation of the patient experience. So most people that are interested in this good death concept and measuring it are relying on proxy reports, usually for family. And there are several different measures that have developed that are trying to capture this. This is the one I use in my research, the Quality Time and Death Questionnaire, which I think is really the best one available at present. It's the one that there has been the most research done on. There's also some research that's been done using just sort of single item ratings of the quality of death. But this is the one that I chose to use for my project. I don't want you to worry about all the individual items, but I want to give you a sense of how this measure is constructed, because when I tell you about some of the results from the study, that'll inform the meaning of those findings. There are 31 items in this measure, and they capture six domains of the dying experience. There are two questions that are posed for each item. The first is the frequency with which an event happened at the end of life. And the second is the rating of that aspect of the patient's dying experience on a 0 to 10 scale, where 0 is a terrible experience and 10 is almost perfect. And it's that second quality rating control that the respondent is asked for their rating of that aspect of the patient's dying experience. So it's not necessarily whether pain is unaffected, the quality of the experience, just whatever level of pain control management. So as I said, it's really one of the best measures available. It tries to cover this concept that's very broad. The 6 domains are roughly symptoms of personal care, preparation for death, the actual moment of death, and what that was like, whether they had time with others and the quality of that time, treatment preferences and whether those were followed, and then what the instrument developers call whole person concerns, which includes everything from dignity to the provision of emotional support. So to date, there haven't been any studies that have looked at the relationship between the quality of dying and death with this type of measure and either patient and caregiver antecedent adjustment. So what was the distress and experience of patients and caregivers before the dying experience, or the relationship between quality of dying and death and specialized palliative care. Gail had mentioned that as a possible predictor of better quality of death, or the relationship between quality of dying death and then primary caregiver bereavement and morbidity. So is there a relationship between what the experience at the end of life and the caregiver and distress? So I've been involved in this in a longitudinal study, which is looking, this is the overall study model, and it's trying to look at all these different factors and how they're related. So both patient and caregiver factors, these are measured before patient death, and they include general characterological facets, as well as depression and hopelessness and desire for hastened death and pain, physical symptoms. Caregiver factors, again, measured before patient death, so characterological aspects and also their own depression and level of hopelessness. Whether specialized palliative care was received and for how long, and how those factors are linked to quality of death, and then in turn how those factors are related to bereaved caregiver distress and function. So it's as you can imagine, a long and complicated research process. I'm going to talk to you a bit about some cross-sectional results that come from time 2 in this study. So the way the study procedure works is patients and their caregivers are entered into the study. These are all people with metastatic disease who are being seen at Princess Margaret Hospital in outpatient oncology clinics. And they are assessed at time 1 in terms of these characterological and symptom measures. And then there's a variable time period, obviously, between study recruitment and patient death. After patients have died, 8 to 10 months later, We are then re-interviewing caregivers and assessing if that quality of the dying and death experience is related to stress. And then there's a bereavement distress follow-up in time 3, which is 6 months after that. So as I said, I'm really going to focus on this cross-sectional, this time 2 piece where we can look at the quality of the dying experience and some of the bereavement distress. So the large study has multiple objectives, but in terms of this cross-sectional piece, what I was really interested in is getting a sense of what is the quality of the dying and death experience for metastatic GI cancer patients, because we know very little about what they're actually experiencing. And then second, what's the relationship between this quality of death and the bereavement distress of these caregivers? So I'm going to present you some preliminary results, and Gail, I'd like you to forget everything I tell you after I show you these preliminary results, because we're only partway through this study, and I have a sneaking suspicion that a year from now my findings are going to look somewhat different. So I'll give you a taste of what we're finding so far, but don't hold me to it. If you hear me speak about this again or read about it in the literature. This is the sum to give you a sense of what the sample that I'm working with. I have analyzed 79 patient deaths. So this is some of the patient demographic information. I'll just draw your attention to the fact that the mean age is 63 years, but there's quite a wide range. Patients were anywhere from 34 to 89 years of age. The sample's about 50-50 male and female. Mostly Canadian-born, fairly well-educated, fairly affluent. 70% had a family household income greater than $60,000. Fairly well supported. Very few people in this study live alone. Most were living with family or other caregivers. In terms of the illness variables, in my sample, the majority are gastrointestinal cancer patients. Also interesting is the amount that received some palliative care. So 81% of the sample received some palliative care prior to death, with a mean length of palliative care involved of 77 days. And that's a quite high rate, 81%. That's actually higher than the average for a hospital. I can't remember very what it is, what the percentage is for patients that receive some palliative care.
By the end of life, it's up to about half.
So 50%, but my sample is 81%, so it's much.
But still, people are receiving it late.
Right. And in my sample, this mean is 77 days, and that is anywhere from several days prior to death to, in one case, there's a subject that had 3 years of palliative care. About 43% die at home, and the mean time from diagnosis to death was 33 months. In terms of the caregivers, I just want to draw your attention to, first of all, age. Caregivers are a bit younger than the patients, and that's because while the majority are spouses, some are the children or family friends of patients that have died. Also, I'll just draw your attention to gender. 82% of the caregiver sample are female, and that fits with a lot of caregiver research for 2 reasons. One, most studies find that women tend to agree to this type of caregiver research more frequently than male caregivers, but also the majority of informal care is provided by women, which I think is really important to emphasize. Again, fairly affluent, Canadian-born, fairly well-educated. And in terms of bereavement distress, I'm not going to go into a lot of detail about the level of bereavement distress, except to say that we looked at depression, we looked at stress response symptoms, we looked at grief symptoms, and this sample, as it looks, these findings fit with other non-clinical bereaved caregiver samples. So these people have around the level of distress that you would expect to see in a non-clinical bereaved sample. So people that aren't coming for bereavement support, but nonetheless have lost a significant one, around 10 months. So back to one of my objectives. So what is the quality of the dying experience for these patients? So this is a histogram of the total scores for the quality of life measure. Remember, this measure is based on those quality ratings for those 31 items, and the total score ranges from 0 to 100, where 0 is a terrible death and 100 is an almost perfect death experience. And what you can see from this histogram is that the results are skewed. The sample mean is 68, and the range is around 45 to 93, and there are no total quality death scores in what is considered the poor range, which is 40 and below. Now, this surprised me. I wasn't expecting that quality dying death for cancer patients would be overall rated so positively by caregivers. If you compare this to other research with this measure, that other research, for instance, done in large community samples, not with other illnesses other than cancer, you also see a skew. You also see an average around 68, but some of the other research has shown larger range of scores. So some scores in this very low range, but ours does not. And if you look actually at other attempts to capture the quality of death, for instance, single rating scores of the death experience. So was this a good death? Yes or no, or how would you rate this death on a scale of 0 to 10? Again, that body of research also shows that on average deaths are rated in this moderate to good range on average, which is interesting. I don't think it's what people expect. There's a lot of fear around death or sort of death anxiety with the dying experience, so it's surprising, a little surprising to me that these are rated so positively. But remember, those are total scores. Then there are the 6 domains that make up that measure. So if we zero in on those different domains, these are the mean quality scores for those specific domains. So here we see a bit more variability, with symptoms and personal care being the domain that tends to be rated the lowest. But these other domains, death preparation, time with others, treatment preferences, those whole person concerns, which includes dignity, which is an important issue in the actual moment of death, those are all rated above 60, which is in the good range. So again, you get a little bit more information. If anything, it seems to be the biggest area of concern, symptoms and personal care. And then if we want to look at domain scores, just the ones that were in the poor range for each of those 6 domains, what is the frequency of domain scores in the poor range? And again, symptoms and personal care, you can see this is the real area of concern for most people, with about 30% scoring the poor range. But these other domains are not so problematic. Time with others, really no one is rated that domain in the poor range. Death preparation may be a bit more of an issue at the moment of death. So if symptoms and personal care seem to be one of the biggest areas, problematic areas, let's zero in then further in that domain. What are the items that make up this domain? And these are the domain items, and these are the mean quality scores. Remember, people are rating these questions on the 0 to 10 scale. And what's interesting, I think, here is that, remember I mentioned pain is pretty much one of the #1 things people talk about when you ask them what they want to avoid at the end of life. And this is actually not being rated as a huge area of problem for the majority of respondents. It's around 6 out of 10 in terms of quality. But these other areas, whether the individual had control, whether they were able to feed themselves, whether they had bladder and bowel control, whether they were able to breathe comfortably and had energy to do what they wanted to do, those are all below 6. And energy seems to be the most problematic. The other thing I think is interesting, though, about these items is that when we think about intervention, what could we do to help? A lot of these aspects are not necessarily things that as healthcare providers we can have much control over. Pain, certainly. We can give pain medication if people are willing to take it. But for instance, energy and fatigue, it's a problem it's hard to treat at the very end of life. And similarly, bladder and bowel control and having control over what's going on in energy, etc. So we'll come back to this at the end, but this is getting me thinking about if we wanted to do something about this, what might we do? We might have to be thinking about interventions other than treating with medication to capture some of the symptoms. And maybe what we're going to need to do is focus on better preparation, better more realistic expectations about the life experience that might then make the experience experience. So remember, the other things I was interested in are what are some of the factors that may influence whether someone experiences a good death or a poor death. So this is patient characteristics and the quality of dying death scores. And these are the means are being compared. For instance, female gender versus male gender, and then t-tests are done. What I want to draw your attention to on this slide is that of all of these patient characteristic variables, the only one that looks significant is place of death. So it looks like people who died at home had slightly better quality dying death ratings than those who died elsewhere, whether that was in a hospital or nursing home, etc. In terms of caregiver characteristics, this seems to be where the money is. There are far more caregiver characteristics that seem to be significantly associated with the quality of death. So caregiver age, so older caregivers are reporting better quality dying death for their loved ones. The length of the relationship looks significant. So if you've known a patient longer, people report better quality. And then some of these were being to stress measures. So stress response symptoms. If you have more stress response symptoms, your rating of quality of life is lower. And grief symptoms. So the more grief symptoms, the lower the quality of life is. And then you put it all together in the regression, and remember, Gail, I'll tell you this and then you forget about it. But I can't help it. I continue to do these regressions as we get more and more larger sample size, but we're not finished collecting data, so things will likely be different when we get a larger sample size. But right now, the variables, when you put it all together, the variables that fall out as significantly associated with quality of death are caregiver age. So older caregivers have been reporting better quality of death. A non-spouse relationship being associated with better quality of death. So spouses are reporting poorer deaths for their loved ones compared to non-spouses. And those people who have less stress response symptoms are also reporting better. So then back to these two cases that I presented to you at the beginning. From what the research shows, we go back to these two cases and look at who would have had a better quality of death. I think Gail was saying maybe Grace would have been mentioned to have better quality of death because of her long palliative care. This was the woman who was 70, unmarried, living alone, who had GI cancer for quite some time, and followed by palliative care for quite some time. Her caregiver, this individual I interviewed, was a female friend, also unmarried, who was living alone, and they had known each other for about 4 to 5 years, and her grieving scores were you were right. It was Grace that had comparatively the better quality of death score compared to Dan. Her total score was 88.9. What I didn't tell you about Grace is actually she was a nun, and her caregiver was a nun. And that actually colored greatly her dying death experience and also the kind of support she had. So she had no family per se, but she had a very strong network of individuals that she could rely on. Pretty much across the board, these domains were rated positively. And then here are just some of the quotes. I think just also want to give you a flavor of what these interviews are like and some of the nuances of the subjective experiences with quality of death. For instance, in terms of pain, her caregiver said that Grace had pain some of the time, but she rated it a 9 out of 10 nonetheless. And she made the point that it was a good experience because the medication made Grace confused at times, and she didn't want to be in that state. So she was once again willing to take this trade-off and have more pain and less confusion. So again, not just having no pain is not necessarily the be-all and end-all. It's having what you want and making those trade-offs. In terms of control, she rated that very highly. She talked about the fact that to the very, very end, Grace was able to give direction about what she wanted and able to really choose how she wanted to die and have that fulfilled. In terms of dignity and self-respect, again, you get the sense that Grace had a lot of control right up until the end, and she was able to ask for what she wanted from individuals and have a sense of living to the end. In terms of time with others and time spent alone, she spent time alone with Vivid at the time, but this was also rated positively, again, because it's what she wanted. She was able to direct and have people around her if it was all right with her, and also send people away if she was uncomfortable with that. And then around death preparation, here's where her faith really came in. This was rated very positively, and her caregiver talked about her knowing that she was going to face loss. She was actually the last one in her family to die, and so there was a sense of loss for a whole generation, but she had connection with other family, and there was a sense of legacy and treasuring what she had taught them, and that colored her experience of death. And then even in place of death, she died in a nursing home. This was rated very positively, and again, because she got to decide when she wanted to go, and that made all the difference too. So comparatively, Daniel's quality of dying death is the other individual I mentioned. This was rated comparatively lower. Remember, none of the total scores in my study are in the very low range, but Daniel's was in this intermediate range. And he is a 56-year-old man with 2 children and fairly high household income, who had very little palliative care, just a few days, and medical. And I interviewed his wife. They'd been married for 3 or 4 years. She also had fairly low distress scores compared to the sample means. And this is a picture of the domain. So Daniel's total score was 50.2, and this is the mean quality scores for these different domains. And you can see that, again, symptoms and personal care seem problematic, and also the moment of his death and the nature of that was ranged. And then here's some of the details. In terms of pain, his wife talked about the fact that he wasn't a person that could feel the pain, so for him it was very important not to be in pain. She rated that fairly positively, that he had a good bit of control, pain control. In terms of control of what was going on around him, she talked about having lost his mobility, and he being a very active person, so he didn't have a sense of control once that was gone, comparatively to Grace, who, despite the fact that she was very ill and in a nursing home, was still able to direct what happened around her, and that she still had it, maintained a sense of control, whereas for this very active gentleman, losing his physical mobility took that away from him. His wife talked about the dignity and self-respect really wasn't an issue, so she rated that sort of not including that and intermediate range. She talked about how he was not what he wanted to spend time alone, so it was very good that he had people around him to alleviate his distress, compared again to Grace, who was somebody who appreciated and valued some time. In terms of death preparation, his wife wasn't able to tell me about his fear of dying. She didn't feel she could answer that. When I asked her about whether he said goodbye to loved ones, she said no, and she rated that very poorly, and she said for her it was terrible, and for one of his brothers it was terrible, and she said, I just don't think he didn't know, so Daniel wasn't necessarily where he was dying, and she said, I honestly think he thought he was going to be home from the hospital. So again, this idea of preparation being important compared to Grace, who had more of that. And then also just, I think what gets highlighted in that quote is this issue around empathy and mentalization, and the fact that for his wife, what really comes through for her is her own experience of that. And she's giving the information about Daniel, but she's also coloring her responses with her own experience. And so it gives you another sense of that the measurement of this is very complex, and you're getting multiple perspectives often on the experience. And then place of death, this was hospital, and she rated that very poorly, 0 out of 10, and talked about how it was terrible. She said, I promised her to keep him at home to the very end, and it was at my insistence that he go to hospital for blood transfusion. That's where he died, so she felt a little guilty about that, again, coloring her rating of that aspect. So, in summary, I hope what has been emphasized, and if I want to take away anything, it's that the good death and the quality of the dying death experience is very complicated. There are so many dimensions of the experience. It's really individually determined, and so there is no one good death. So measurement of this is really complicated if you want to do this. But it's becoming more a focus of research, and there's more rigorous research in this area all the time. I'd like to also emphasize that symptoms and circumstances of death alone, so pain and where you die, that alone doesn't tell us how the death is experienced and how it will be judged. From the preliminary analysis, as I said, these total quality of dying and death evaluations were not in the poor range, and that surprised me, as I mentioned before. And I think there are a lot of explanations, possibly for this, and I've been thinking about what is the high rates of palliative care that this sample is receiving. As I mentioned, 81% had some palliative care, which is fairly high. So are they getting very good care? And that's why the quality of that care is very good. Even though palliative care can seem significant in terms of its relationship to quality of dying death, we have so few subjects in that no palliative care group. I think that's meaningful result. The other question on mine is around recruitment and response bias. So am I managing to capture the caregivers who had the good experiences? Are they the people that are willing to talk to me in this research? And that's always a question, particularly in research like this, where people often get very low recruitment numbers. In my study, it's about reporting on almost 40% of the potential sample of deaths. About 40% of caregivers are ready to partake in the study, but there's 60% who are not capturing it. So we can't necessarily say that this represents the entire group. The other idea is it possible that family caregiver proxies are overestimating the quality of the death experience compared to what patients may have said, the fact that interviewing them in that last week of their life? Always something to keep in mind. Although, remember when I talked to you at the beginning about proxy research, other types of proxy research show that caregivers tend to rate quality of life and symptoms lower than patients, so that seems less likely, but it's always a possibility. And then the idea that maybe the palliative event is recalled by caregivers is being altered in some way, for instance, by their need to perceive the end of life as positive. It's so important for family caregivers to see that as positive, or is that part of the grieving process? And that's part of their responses. Also, just to summarize again the results from the preliminary analysis, it looks so far with the small sample we have that poor quality of death is associated with particularly caregiver factors, so younger caregiver age, a spousal relationship, and high stress response.
So under the second category, should expectations be there as well?
I think absolutely it could be a possibility that that's correct. And I didn't talk about this today, but as part of this research, I've done some qualitative piece, which is actually looked at what are the influences on the respondents' subjective ratings. So what is the information that they're using to make these judgments, these quality judgments? And often it is about expectations. It's about, this isn't what I thought it would be like, or past dying death experiences. So sometimes for people who've had very horrific dying and death experiences in the past, this one was comparatively better. So I think expectations do play in how people are rating. So that is a good segue then into, and I'm talking about potential interventions at the bottom. And that's one possibility, is that we could prepare patients and families better. We might be able to alter some of those expectations, and that may lead to other life experiences. And I think also in terms of intervention, probably the idea of targeting those who are younger is really important, because they seem to have the worst experience. Caregivers certainly are rating all that. Of course, if they are young, there also seems to be a potential relationship between the younger patient and the well. But this is only the beginning of the story, and there's a lot more data to gather, and we're hoping that the sample size will be much larger by the time we finish, so we'll be able to look at many more factors, and I think the results are meaningful. We'll be able to look at some pre-death patient caregiver variables that I mentioned to you before, and how those are related to both quality of life and grief and distress, and that might give us a bigger picture about the factors that we need to target. And then I think if this pans out that, for instance, age and length of illness and length of relationship and nature of relationship are important predictors of quality of life and death, then further exploration of those factors would be interesting to look at. For instance, this idea of death acceptance and death preparation, and how that may influence the subjective experience. Interesting. So that is the end of my that's acknowledging my research team, including Garrett, who's my PhD supervisor, and sat through the umpteenth presentation of my study. So I don't know there are any
So I got
questions or
a,
comments?
one of the things you addressed in a recent paper, the quality of finding death was the cultural dimension. Can I say a little bit about this from a global perspective?
Yeah.
What do you think the cultural or
Yeah.
national aspects of the data may be?
Well, and
How do you expect that to influence?
I think it's a really important question. We know so little about it. Some of the research that has been done, and I'll just come to this. So this is the paper Gary's referring to. We were looking at mostly qualitative research that was trying to, as I mentioned to you before, capture what people want at the end of life, how they would define a good death. And there was some of these, the majority of these papers were North American or Northern European studies, but there were a few that were not. And some of those non-North American European authors commented on their results compared to this more Western literature. One finding is around the relationship between the individual and community being very important. So there are cultural values in terms of autonomy and individuality are going to play into how people define good death. So for instance, the idea of wanting to maintain control right up into the end of life, avoid dependency, those are values in North American and Northern European society. So that colors what people want. This, even the idea of right to die movement is about that. People want to say in where and when they go and how they go. Whereas that's maybe less important in cultures where the family and community are relatively more important. There was one study that was a Japanese study specifically talking about that. That was the idea of autonomy and control. It was not a big heavy issue in there. And then, but I think another really important factor is resources and nature of health care that's provided in communities. So there are international differences in the availability of good palliative and end-of-life care, even good access to hospitals and pain medications, and so that also colors these priorities very much. We'll be able to answer some of these questions because there's actually an arm of this study that I'm doing that's going on in Jerusalem. So we'll be able to compare the dying experience here in Toronto compared to cancer patients here in Jerusalem, and potentially someday in China and Beijing as well. So hopefully we'll be able to talk about that, look at these different communities and what the dying experiences for cancer patients. Nice segue.
Are there any questions out there as well online?
I have to say, for a small crowd, you're attentive and lovely to speak to. Lots of nodding and smiling.
Excellent presentation, and this is very interesting work. I think this is something we haven't known a lot about, and it's complicated work to do, to locate people and to get retrospective evaluations. And it's very interesting assertion to this question of the multiple perspectives, the perspective of a caregiver being as valid as the perspective of anybody else in terms of the quality of death. This is very important research. I think we will have a significant influence. So thank you.
Thank you.